Welcome to Bamboo Health's July webinar. Thank you for joining us. I'm Allison Matheson, Senior Communications Manager at Bamboo Health, and I'll be kicking things off for us today. First, some housekeeping items. Participants are muted but are able to put questions in the chat. We will answer any questions for our presenters at the end of the webinar. If you have questions beyond what's covered, you're welcome to email connect@bamboohealth.com and someone will follow up with you in the very near future. Bamboo Health provides one of the largest, most diverse care collaboration networks in the country. Our network enables providers to improve whole person care with a full view of their patient, including physical and behavioral health, all within the clinical workflow. The goal is to improve health outcomes and provide more efficient and effective use of resources. Our vision is to revolutionize care collaboration for the improvement of whole person care, and we're happy to have you here with us today. The focus of today's webinar is the 988 initiative. A week and a half ago, on July 16th, nationwide it became possible to dial or text 988 and connect with around 200 regional crisis centers that make up the National Suicide Prevention Lifeline. The goal for 988 is to be the behavioral health version of 911, giving people an easy to remember way to access behavioral health resources. While the change happened regardless of any other efforts, states are looking at the switch to change how they respond to mental health crises to better serve and help their citizens. Today we have two presenters with us to walk through some of what this means. I'm joined by Senior Director of Government Affairs, Vatsala Kapur, and Senior Director of Behavioral Health Solutions, Gina Gibson. And I'm going to give a brief introduction for both before I hand over the reins. Vatsala has over 2 decades of experience in health policy and public health. Most of her career has focused on healthcare delivery system and payment reform initiatives at the state and federal levels, where she served as a policy advisor and consultant. Prior to Bamboo Health, Kapur served in a variety of roles in organizations, such as at the Centers for Medicare and Medicaid Innovation and in the office of Colorado's previous governor, John Hickenlooper. Kapur holds 2 master's degrees from the University of Texas. 1 degree is in public affairs and the second is in Latin American studies. She also has a bachelor's degree in political science and history from Colorado College. In addition, she sits on several boards, including Next 50 Initiative and World Denver. Gina Gibson has worked in the crisis space for more than a decade. Prior to Bamboo Health, she was the Chief Operating Officer for the contract running the Georgia Crisis and Access Line, GCAL, and was responsible for providing non-clinical oversight for both the Crisis Call Center and Mobile Crisis Response Services. She helped design and build an enhanced structure to operate and support mobile crisis services for more than 100 of the 159 counties across the state. Prior to crisis services, Gina worked in human resources in a variety of industries and served in the U.S. Army for nearly 9 years. Thank you for your service, Gina. And thank you both for being here today. I'm going to hand things off first to Vatsala.
Thanks so much, Allison. It is a pleasure to be with all of you this afternoon. I wanted to spend a few minutes talking about the evolution of 988 and start with talking about and drawing some parallels between 988 and 911. 911 was launched in 1968, and there's a cadre of responders that respond to the 911 system, including police, firefighters, and paramedics, in an effort to address individuals with experiencing mental health or substance use disorder crisis. The 988 line was launched, and it's really focused on addressing behavioral health emergencies, including suicidal ideation, mental health crisis, and substance use disorder issues. The dispatch response teams are mental health professionals and include mobile crisis dispatch teams, and those individuals help individuals in crisis connect to treatment and resources. On July 16th, as Allison mentioned, the 1-800 number that was launched in 2005 was changed over to a 3-digit number, 988, which we're very excited about. Next slide, please. So this attempt to make it easier for people to access behavioral health resources is in part because 911 became the locus of a lot of calls for individuals with behavioral health needs. And with the 1-800 line that was launched in 2005, and with its transition to the simple 3-digit number 988, the hope among policymakers across the aisle is to direct individuals who need services to the appropriate response quickly and efficiently. Next slide, please. The 988 Suicide and Crisis Lifeline was formerly known as the National Suicide Prevention Lifeline. The Substance Use and Mental Health Services Administration within the U.S. Department of Health and Human Services and Vibrant Emotional Health launched the original Lifeline in 2005, and the Lifeline system is comprised of a national network of more than 200 local crisis centers across the U.S. Next slide, please. So we have seen a pretty dramatic uptick in calls received by Lifeline centers since its inception in 2005. The first year, Lifeline centers received approximately 50,000 calls. In 2008, when the 1-800 number was changed from 1-800-SUICIDE to 1-800-273-TALK, the call volume surpassed 500,000 in just 1 year. By 2021, Lifeline centers were receiving more than 2.5 million calls annually. And with the introduction of the 988 number, we believe that is going to continue to grow exponentially. Next slide, please. One of the foundational policy building blocks to make 988 happen was a rule that was adopted by the Federal Communications Commission to implement 988 as a universal mental health emergency number, much like 911 is for medical emergencies. The President signed the 988 law and went into effect to take effect in 2022, and that law was signed in 2020. Since then, states have been working hard to prepare for the introduction of 988. As of July 16th, calls and texts can now be routed to any individual that dials the 988 number to those 200 regional crisis call centers across the country. Next slide, please. Just in the first week of the launch of 988, Lifeline saw a 45% increase in calls. 96,000 calls, texts, and chats were received just in the week between July 14th and July 20th. This is not surprising given the significant behavioral health crisis that our country is experiencing right now, and the significant need that individuals and communities have across the country. Next slide, please. So SAMHSA has really taken a leadership role in helping to make this happen. We want to applaud the work of SAMHSA in working with states and with other key stakeholders, as well as Vibrant, to make this possible. I won't read all these quotes, but I think one of the most important takeaways from this 2-year implementation process since the law was signed in 2020 is that this is an evolution, and it's an incremental effort to build a transformed crisis care system in our country. that meets the needs of people when they need it. And this is going to take time and effort on the part of federal policymakers as well as state legislatures across the country to ensure that we have the infrastructure both to respond to the calls and chat and text that are received, as well as provide adequate referral to those individuals in a timely fashion. Next slide, please. So SAMHSA distributed $282 million in funding to states last year to basically support strengthen staffing for Lifeline Center operations. In addition, the American Rescue Plan Act, or ARPA, also has opened up the ability of states to request Medicaid funding for mobile crisis services, which will be a critical factor in the ongoing sustainability of crisis programs across the country. Next slide, please. However, there is going to be a need on the part of state legislatures to find additional funding to augment whatever federal support becomes available to ensure the long-term viability and sustainability of the crisis system. And to that end, a number of states, next slide please, have enacted legislation to address the need for state funding to augment federal funding. And this slide represents states that have enacted legislation this year that is in some capacity related to 988. In some cases, these are study committees that state legislatures have set up. In other instances, they are efforts to find funding through state dollars to augment federal support for 988. And we anticipate that additional states will enact legislation in a similar vein in the coming year. So with that, I will turn it over to my colleague Gina for some more information on 988.
Thanks, Vatsala. 988 is live. Now what? Next slide, please. According to a RAND Corporation survey conducted as part of a white paper published last month on 988 preparedness, more than half of the 180 behavioral health program directors surveyed said that they had no part of the strategic planning for 988. Although these responders were aware of resources from SAMHSA, Vibrant, the National Council, and others, that awareness did not translate into a feeling of being prepared. As for funding, only about 16% of respondents were involved in budget preparation. So if the majority of the folks responsible for managing the services critical for 988 success weren't involved in preparing for the launch, how will this knowledge base be integrated into informing best practices for the future? And what about the public's awareness? Next slide, please. To gauge public awareness of and support for 988, NAMI commissioned a public poll that conducted over 2,000 interviews of participants 18 years of age and older. The interviews were conducted from May 20th through the 22nd, a little less than 2 months prior to 988's launch. What they found was that more than 2/3 of respondents had never heard of 988. Now, some of that is intentional, as states are rightfully tying their public information campaigns to the level of awareness, and the national campaign was adjusted accordingly. NAMI surveyors also found that while the knowledge of 988 was not widespread, the support for crisis services is strong. Next slide, please. More than 4 out of 5 adults surveyed believe that someone in a mental health or suicide crisis should be responded to by a mental health professional and not law enforcement. As we all know, involvement with law enforcement can be scary and traumatizing for some, regardless of the reason. 85% of Black Americans surveyed said they fear that a police response to a mental health or suicide crisis will result in them or their loved one being harmed. That's 21% higher than the general population's level of fear, and an important consideration when developing response protocols. Next slide, please. Most survey respondents agree that access to mental health resources needs to be improved for communities that have traditionally been underserved by mental health systems of care. This includes people who are homeless, have low income, are young, people of color, and LGBTQ people. Since 89% of respondents agree that everyone deserves quality mental health care, this presents a unique opportunity for us in this space to ensure our service provision, whatever form that takes, is indeed inclusive of all persons within our service areas, and that the voice of the consumer is reflected in our work every day. This includes incorporating those with lived experience in our service provision, recognizing their expertise as a value, and compensating them accordingly. So how do we do that? Next slide, please. SAMHSA's Best Practices Toolkit outlines the 3 core services for an integrated, no wrong door behavioral health crisis system of care. Someone to talk to in the form of 24/7, 365 crisis hotlines staffed by caring team members who answer calls, texts, and chats, so individuals in crisis or those reaching out on their behalf can do so via the medium of choice. Community-based mobile crisis teams provide the someone to respond 24/7, 365, whether to a crisis under a bridge, in a McDonald's, at a shelter, in a residence, etc. Crisis receiving and stabilization facilities provide a place to go, including 24/7, 365 walk-ins and first responder drop-offs. The national workforce shortage is requiring providers of these core services to reimagine their service delivery methods. For instance, a clinically staffed crisis call center may be staffed with trained volunteers, peers, and non-licensed paraprofessionals who are clinically supervised and supported. Mobile crisis teams may be led by licensed addiction counselors for substance misuse responses or by restricted licensed clinicians in safe settings. Crisis receiving and stabilization facilities may be certified community behavioral health clinics with licensed clinical staff cross-trained to support multiple service offerings. Certified persons with lived experience should be incorporated into each of those core services at all levels and is a force multiplier to help address staffing shortages. That's easy for me to say. Next slide, please. No system can morph overnight to become the ideal outlined in SAMHSA's Best Practices Toolkit. However, with 988's launch, each system needs to be able to minimally answer the phone. Historically, call center staff have resolved about 75% of these crises during the call. That call resolution percentage is trending down as new, less experienced call center staff are facing uncertain increases in the number of calls and the severity of those calls. Adding resources such as mobile crisis teams and access to treatment providers are critical in rounding out community services. Next slide, please. Another force multiplier to help offset workforce shortages is technology beyond telephony. Software solutions that facilitate and support these core services and are interoperable with existing platforms is key. This includes capturing the right data elements during the least disruptive time in the crisis continuum to get the individual the help they need as quickly as possible. Next slide, please. Bamboo Health has been working with states for more than 20 years, including over a decade of delivering behavioral health solutions. We have demonstrated experience in understanding a whole person care from both a physical and a mental health perspective. We have launched or are in the process of launching behavioral health solutions in 14 states, working with roughly 1,000 treatment providers and several hundred hospitals across those states. Our behavioral health solution is an integrated system that captures an individual's journey from intake by the 988 call center through disposition, including mobile crisis dispatch and referral for evaluation in our treatment. It includes complementary clinician and public-facing portals to connect providers and consumers to substance use disorder and mental health treatment providers. Referring providers can communicate with receiving providers, see bed availability in real time, and refer patients to the appropriate level of care. We don't just sell you software. We actively listen to your pain points and match our technology solutions to address both those needs, as well as assist users to make the most informed decisions along the individual's care journey. Our approach is consultative and collaborative, and we readily share lessons learned along the way. Next slide, please. So how do you know what's working and what's not? It's not enough to just provide the services assisted by technology. You also need to measure how successful your programs and the entire crisis ecosystem are performing. Being able to show value-based outcomes in terms of harm reduction, resolution at the most appropriate level in the crisis continuum, and law enforcement man-hours saved are some of the measures of success SAMHSA outlines in its national guidelines. Next slide, please. Bamboo Health's technology not only facilitates service provision, it also provides the data analytics to track and trend performance. This insight allows you to make informed decisions and provides actionable data you can use to support service provisions and funding requests. Next slide, please. That actionable data includes real-time situational awareness to assist call centers with determining the appropriate level of care, availability of that care, and appropriate disposition or linkage to care, whether that's through identifying, locating, and displaying the closest and applicable mobile crisis team, visibility into the next available appointments or available stabilization beds, and connecting the individuals to services, or capturing date and time stamps that demonstrate the system's effectiveness and timeliness in getting individuals to care along their crisis journey. So how does all of this translate to action? Next slide, please. Bamboo Health's crisis management system, which is a subset of our behavioral health solution, is currently live in 2 states, both of which launched this year. Since our launch, our technology has been used to dispatch mobile responders more than 4,000 times. So far, over the nearly 3-month period of May through July of this year, 1 state has had over 350 mobile responses to adults. More than 28% of those were resolved in the community, while about 44% were referred to downstream care. All functionality from the call center receiving the call and dispatching mobile crisis to the mobile responder referring the individual to services was completed within our behavioral health solutions platform. Now I'll turn it back over to Allison for Q&A.
Thank you both so much for the presentation. If you have any questions, you can drop them in the Q&A box, and I will read them out to our presenters so that they can address them. First off, in general, what are you seeing for states in their preparedness for 988? Not sure who wants to go first.
I can take I'll take that one first. This is Gina. So states are across the board. Some have completely built out crisis ecosystems and they are ready to just augment those services, while others are in the planning stage and they're determining exactly what their needs are and how to operationalize those needs. At a minimum, most states have at least put in and identified 1 988 call center that can take the bulk of these calls as they're looking to build out in-state backup centers. They now have the ability to rely on out-of-state backup centers within SPL, but as everyone knows, the best practice is to have in-state backup so that there's a local response to calls and local services are available to those individuals in need.
Great. Vatsala, any thoughts from a legislative perspective? I know you showed that map, but anything else that we might be missing?
Well, yeah, I mean, I think that states have an opportunity to think holistically about how to structure the response system, and some of that is that there needs to be more behavioral health professionals that are providing those services. But a piece of it too is organizing the professionals that are in the field right now and getting visibility into where they are and their specific specialties and their expertise, so that individuals can quickly get routed to the right treatment. And policymakers can play a huge role in helping to advance that more holistic view of the state of access of services.
Great. From your seats, what do you think the biggest limiters are to make 988 truly on par with 911, you know, as we know it today? You know, children knowing how to dial the number, learning that at school. What do you think are the biggest limiters right now to making that a reality?
Time and adoption. 911 did not become what it is today overnight. It took some 50 years to get 911 to that state. Now, obviously, we know 988, and we hope 988 isn't going to take 50 years to get there, because we think our behavioral health system is more involved in that, but it is not going to happen overnight. And then widespread adoption. repetition is key. People understanding that now you can dial a 3-digit number and still reach the same call center that you were talking to when you dialed the 10-digit number directly. Having a more unified approach across the board, and then a coordination, 911 and 988 coordination. Having a unified platform for 911 so that it makes it easier for the 988 centers and the mobile crisis responders to reach out to them, and the service providers for them to reach out to them, and being able to share that data bidirectionally from 911 and 988 centers.
And,
Yeah,
and just to add to that, I think that there's an opportunity for 911 dispatch, the individuals who are actually dispatched to sites from 911 and 988 to evolve and strengthen the way they work together to address specific situations in a way that brings the needed services and help to individuals in crisis, but also doesn't make them feel fearful.
Vatsala, that made me think, have you seen anything in the government-wise kind of related to that coordination between 911 or 988, or do you think that's a next step maybe to come as both evolve?
There are a handful of states that are already talking about that. So but certainly I think that's something we're going to see more of in the coming few years. And I'm very excited about that.
Great. Well, thank you, ladies, both for your time today. For those who are still on the line, if you have additional questions that maybe come to you later, you're welcome to email us at connect@bamboohealth.com, and we'll get back to you in the very near future. But thank you both for your time, and thank you for the attendees for being with us here today.